Hi, everyone. Thanks for joining us. Meg here in the room. Appreciate the flexibility and apologies for the sort of late notice. There's a number of us that are serving on a legislative commission and needed to be over there. It actually ran a little late, so we rushed back for the meeting. So thank you for taking or bearing with us when we had to change the time up a little bit. I'm just looking at participation, and I think there's maybe a couple more members of the advisory council we're expecting to join. So I'm just going to give it one more minute to let those folks join, especially at least one is coming over from the same commission meeting that we were at. So hold with us for maybe 30 or so more seconds, and then we'll get started. Okay, everyone, thanks again for bearing with us. I think we've got as critical a mass as we're maybe going to get for today. I know we had several folks who let us know in advance that they weren't going to be able to make it to today's meeting. So I'll just jump in and get us started. Given that we've got a little bit less time than usual, given the conflict that many of us had, a relatively brief agenda for today, at least in terms of bullet points, so there's some substance in here. We wanted to start with just an update on comments that we heard at the annual public hearing that we held back at the end of September. And then do an update on development of the policy concept on provider price regulation. So we kind of set up that conversation a little bit at the last meeting and wanted to take that back and do a little bit more work on it to bring back to all of you. So we'll have some updates to share on that. But moving right into the annual public hearing comment summary, I'm going to hand it off to Haley to take over and walk through some brief slides that summarize that feedback that we received.
Yes, so we had our third annual public hearing at the end of September and had a little bit lighter participation this year than previous years. We had 22 people provide both written comment and live testimony in person and virtually on the 29th. And here's a quick breakout of how we categorized groups that participated in the hearing, but know that that was a group of 22 total comments received for the office, and a large majority of them came from individual consumers, providers, and advocacy organizations. This is a very brief list of general themes from all comment categories, and a theme is defined by a comment we saw come up more than 2 times across all categories. So I'll briefly run through this list. A big one that you'll continue to see as we go through each category is the expiration of EPTCs being a huge concern and barrier to access and affordability, along with federal level Medicaid cuts. We had a lot of general comments about lack of affordability. We had comments about lack of access to primary and behavioral health care, high hospital prices, and consolidated market power. We had some comments about hospital payment plans. We had some comments about lack of anti-competitive contract terms, high labor costs, prior authorization and administrative burdens. And then we had quite a few people raise coverage mandates as well. So here's a quick breakout by category. So among individual consumers who testified, themes, again, 2 or more people brought up was the expiration of the enhanced premium tax credits and rising premiums as a result, coverage denials and fighting with insurance companies about those denials and coverage, unaffordable payment plans or issues with the length of payment plans available through hospitals, and foregoing treatment due to concern about costs. Amongst independent providers, again, cuts to Medicaid at the federal level and expiration of EPTCs, a lot of concern about patients skipping or delaying medically necessary care due to concerns about costs, And it was also raised that access to primary and behavioral health care is a huge issue throughout the state. And then amongst different advocacy groups, we heard about the prevalence of medical debt, again, federal cuts to Medicaid and the expiration of EPTCs. We heard comments about lack of a universal healthcare system, high hospital prices, and anti-competitive behavior in a consolidated provider market. And then these are our other two categories, insurers and hospitals or health systems. I'll note that insurers also includes associations representing health plans. And in that group, we heard about provider market consolidation and ensuing anti-competitive behavior that also leads to high hospital prices. We heard about limits on utilization management and prior authorization. And we also heard about mandated coverage benefits and concerns about ensuing costs that come from those. And then amongst hospitals or health systems, federal level Medicaid cuts and high labor costs. And then in this category, because there were only two participants, a few other touch points were administrative burdens such as prior authorization, broken continuum of care and the costs associated with that. And then the need for a consideration of quality, access, and cost, also known as the triple aim approach when evaluating different policy solutions to healthcare affordability and access. And that is a quick overview of our comments this year.
Perfect. Yeah, I think challenging year in terms of input from the perspective that there's obviously so much happening at the federal level and has been this fall. And also, I think we kind of converged with a time when there was input being solicited about the Rural Health Transformation Program application. So acknowledge, I think it was an extra busy time for everyone in kind of the advocacy space in terms of consumers being kind of engaged and activated to testify too. So still, I think a lot of helpful input, and just wanted to say an extra thanks to everybody who contributed either in person or virtually or in writing to that public hearing. Any questions on what we heard, themes? I think outside of again, response to those federal changes, a lot of commonality in issues that have been brought up before and that I think are very much at the center of a lot of our conversations in this group. Okay, great. Thank you so much, Kaylee, for putting that together and walking through it. So I'm going to move on then to an update on policy development. To kind of revisit, I know we touched on this a little bit during the last meeting, but I wanted to do a little bit of a deeper dive on work happening in other states and realigned a little bit around the proposals that I wanted to do a deep dive on. I think in particular, hospital price growth caps and reference-based pricing that's been implemented in state employee plans. I wanted to do a little bit of a deep dive on. In the last meeting, we also talked about the price caps and public option plans, as well as overall kind of cost growth targets that are more holistic and generally a little bit less stringently enforced, I'd say. But I think as we looked at kind of cost benefit analysis and feasibility, kind of operational complexity, the two areas that have sort of more direct regulation and work in this space kind of stood out. So we wanted to talk more about the structure of those programs and some of the findings from their results. So just to review again, we talked a bit about this in the last meeting. And I'll just say again, I know I always do, but please interrupt me. I'm just going to kind of keep moving through these, but it is a lot. So if anyone wants to pause and ask questions or make comments throughout, just let me know. A price growth cap is generally a limitation on how much provider payments can grow each year. States have linked these to different indicators, consumer price index being used, or gross state product, or Medicare growth indices that are used to determine how much Medicare payments should increase year over year. Some variation in how states have implemented them, whether it's at like an individual service price growth level or kind of an aggregate average of prices, can be applied. They can be applied to all hospitals, or much more commonly, I think, thinking about classes of hospitals where price growth has been sort of problematic or identified as outpacing trend. and can also vary based on baseline prices. So sort of the difference between whether trend in growth has been above average or whether underlying prices are maybe above average or out of step with what's expected in the state. So a couple states have done work in this area, Rhode Island and Delaware. Delaware's law isn't yet implemented. It was only passed about a year ago, so I'm just going to focus on Rhode Island for now. So in Rhode Island, they've been using, since 2010 actually, affordability standards as part of the rate review that they do for state-regulated health insurance plans. And one component of that, there are other components, but one significant component is a limit on the average annual payment increases for hospital inpatient and outpatient services in each insurer's contract. And currently, the way that they measure that is consumer price index plus 1%. So trying to keep up with sort of overall inflation with an additional percentage point for healthcare providers. The state enforces the price growth cap, as I said, through rate review and then market conduct examination. So it is something that formally only extends to the insurance companies the state has oversight over, essentially fully insured insurance, not self-insured employer plans, which do make up a majority of the commercial market. But there is some evidence that there's been an effect from these price growth caps, even in the self-insured market. And what I've heard from regulators and others who have studied this is they believe that insurance companies are generally negotiating rates with providers basically for all of their business. So if they're serving as a TPA for a self-insured employer, the rates are the same in that plan as they would be within a fully insured plan. This is an area where I'm not sure how common that is across states. You know, we've also heard sometimes from researchers who do work in price transparency tools, for example, that they do see different rates of payment. So I think more to think about there in terms of how specific that is to Rhode Island or how much you could expect that kind of phenomenon to exist in other states, but an interesting model here. So given that the program has operated for quite a while, there's been an opportunity to do a pretty significant study of the impacts of this program. A recent one that was published in Health Affairs found that the affordability standards overall resulted in an average of $87.7 million in annual savings. 64 million of that accrued to employers in the state, while 23.7 million went to consumers, in a combination between lower premiums than they would have been without the program and reduced out-of-pocket costs for those consumers, because when prices are lower, co-insurance is lower, for example, as well, and because insurance companies, if they're paying less out in claims payments, you know, have some more flexibility sometimes to, design their plans with a higher actuarial value for consumers as well. By 2022, the authors found that the hospital price reductions in the program, so just that component of the affordability standards, translated into savings of about $1,000 per member in fully insured plans in the state. This is where the savings were lower in the self-insured plans, which may have to do with kind of the translation of this outside of state oversight, but within those plans where the state was really able to monitor and enforce this pretty significant savings for consumers. And then an earlier evaluation of the standards found that they were associated with just under a 6% decrease in total per capita healthcare spending among the commercially insured population. So a bending of the curve. That is, I should say, a study sort of relative to cost without the standard, so not a net decline, but 6% lower than they would have been without the standards. From that analysis, or in addition to that analysis, this is a really interesting graph that is pulled from the Massachusetts Health Policy Commission's 2023 annual report. They themselves were sort of thinking about and discussing how to get a handle on growth of hospital prices. And so this comes from a section of that report where they were discussing Rhode Island's program and comparing it to Massachusetts. And what this shows is the orange line that's solid is hospital revenue in the state of Massachusetts, where the orange dotted line is hospital costs. Solid blue is Rhode Island's revenue, and dash blue is Rhode Island's costs. So you can see at the beginning of the period that hospital costs in Rhode Island and in Massachusetts were very close, very similar, both costs and revenue. Over time, since this program was implemented, revenue grew more quickly at the Massachusetts hospitals, or spending essentially, and so did costs. What's interesting to me is there was not a significant contraction in Rhode Island between revenue and costs after those price caps were implemented. Costs actually grew more slowly while revenue did. So I think it's an interesting illustration potentially of the capacity of caps on what is being spent on hospital services being able to yield some greater efficiency, that there is some ability for hospitals to kind of adjust to changes in revenue coming in and change their cost base to account for that when they're sort of under the pressure to do so. The next item I wanted to touch on in a little bit more depth, or policy structure, is again this notion of reference-based pricing in state employee health plans. So differentiated from price growth caps, where really the focus is on slowing the growth of prices over time, this strategy is more about addressing kind of outlier prices in healthcare plans. So thinking about setting kind of a cap, and in some cases a floor, on what can be paid to eliminate some of the wide variation that we see right now in terms of spending on healthcare services or prices for healthcare services. A couple state examples, and we did touch on these, but shared a little bit more data here. Oregon's is the program that's been operating for a while. That state employee health plan pays no more than 200% of Medicare prices for in-network hospital services, and also has a cap on out-of-network services that's a little bit lower at 185% of Medicare. And there are some exemptions in this, small rural hospitals, sole community hospitals exempted, so focuses more on larger hospitals in more populated areas of the state. And then Washington, just recently this year, passed a similar proposal, I think draws very much from the state employee health plan in Oregon, also used 200% of Medicare as sort of the benchmark for a cap, but is differentiated in that it also sets a minimum payment level. So primary care and behavioral health care services need to be reimbursed by the plan at least 150% of the relevant Medicare rate. So again, given that Oregon's program has been operating for a while, there's also been an analysis and evaluation done of the impacts of that program. At the top line, $100 million in savings were realized over the first 27 months that the program was implemented. Most of that was driven by reductions in outpatient prices. So what this graph shows is the blue line at the bottom being a control group of employees that the authors of this evaluation looked at, while the red line is the state employee health plan. You can see that prices were higher for the state employee health plan than that control group up until the policy was enacted, and then came down to essentially be in line with where that control group of other employees was, and realized significant savings there, about 25% reduction.
Vic, did they look at why the control group prices seem to decline there and after the policy as well?
There was some, I'm thinking more about the cap that they had. I was going to say, I know that they saw that there was actually a small increase initially because people sort of viewed the cap as a floor. I don't know about the control group. Other than that, it looks like that's shortly after 2020, and I'm always mindful of COVID impacts in that time. So I think that, that might be a greater utilization of like lower cost services, which I know we've seen in our data can kind of skew those results. But I'm happy to take a look and report back on that from the report as well.
I'm just curious.
That same evaluation also looked at other impacts. I know, a question about these policies is always, of course there's an impact on the cost, but sort of what are the other impacts on the systems in terms of access? Of course, it's a relatively short period of time that they're looking at, but they found no impacts on access to care. All of the hospitals that participated in the state employee health plan remained in that network. None elected to leave the network in light of the caps. There was no measurable impact on hospital finances, operations, or patient experience of care that the authors could note from the data available. And they also took a look in this model where the policy is limited to just the state employee health plan at whether there was evidence that hospitals had sort of raised prices on other commercial plans in order to offset a decline in revenue from the state employee health plan, and they found no evidence of that either. And I just wanted to note here in thinking about these impacts that the state employee health plan is roughly 13% of the commercially covered population in Oregon. So, certainly not the whole thing, but a pretty significant portion of the commercial market is impacted by these changes. So having touched on a couple of those policies that we've kind of wanted to dive into more depth on and share some results from, wanted to spend a minute thinking about sort of next steps and decision points, I guess, thinking about the framework for moving forward with a policy in this space. And as I was thinking through this, I think I kind of landed on a few outcomes that feel like priorities for me or considerations that are priorities. The first is ability to implement policy without reliance on federal government collaboration. The reason that I bring that up is, in conversations with the HCIFS committee over the last session and others, just a recognition that in the environment that we're operating in right now, trying to create policy where there isn't a necessity to obtain a waiver or obtain approval or rely on sort of federal funding feels very important because there is so much uncertainty and there are, I think, challenges in having confidence in moving forward with a path like that. So trying to think about what is it that we can do really within the state of Maine on our own. Thinking about the reach of the policy to the maximum number of people possible. This is certainly a balance. I think other states have likely weighed this, and I think more narrow applications of policy changes like a price cap or a price growth cap can reduce the impact more broadly on the system, and that's worth weighing. But also I think, we have such acute affordability challenges across not only our individual market, but our small group market, our self-insured market too, that really trying to think about ways that we could reach and provide relief to as many people as possible felt important to me. Prioritizing cost relief for consumers, also, critical and I think a clear part of the mission here for the Office of Affordable Healthcare. But on the other side of that, trying to be mindful of balancing cost relief with investments to improve access. We certainly hear the feedback and the considerations that there are parts of the system where more support is probably needed to bring sustainability or to improve accessibility for consumers. And so trying to find the right combination of these things where we can deliver, again, some relief for people, but without, destabilizing the system or even hopefully finding ways to improve access.
Can I just say, in terms of prioritizing cost relief for consumers, I think it has to be prioritizing cost relief for consumers and employers. It can't be policies that just shift costs onto the employer because they ultimately, as we all know, then show up in higher premiums. So it has to get whatever policy has to get an underlying price, really.
Yeah, that's a fair point, and I probably am intended to use consumers here more broadly. I think in the past we sometimes use kind of end payer too. So totally appreciate that and happy to kind of make an edit to reflect that as well in future. But agree with you, yes, not looking to just try to moderate the impact of cost on consumers. And I've certainly been thinking about that in the context, again, of federal changes happening. That can be an important temporary solution in some cases, but ultimately, we're on a trajectory where even that's not going to be sustainable. So,
Exactly.
Okay, great. So wanted to preview with all of you kind of a recommended policy framework that we are looking to build out and build on, but wanted to give some insight into the direction and get some, early feedback and thoughts. So I'm going to touch on this. It is high level, and then I've got a few more slides about thinking about kind of next steps here and building it out. But at the very high level, I think what we're interested in exploring to move forward with is the idea of setting some reasonable limitations on commercial hospital facility prices. So thinking about a combination of those two models that I talked about, thinking about a cap on kind of outlier high prices for hospital services and establishing a cap on the growth of hospital prices over time in combination. And I say reasonable to say, I think, again, trying to find a balance of what feels feasible here, what in looking at the data that we have available is achievable, but also, again, wanting to at least put some kind of limitations on both outlier high prices and growth. And then the idea of the policy would be to kind of take the savings that would be generated through that cap on high prices and the growth cap and use them for three real priorities. The first is reducing healthcare costs for families and businesses. And what we'd envision here is by setting these limitations on prices, there would be a direct impact on the amount of claims being paid out that would translate into premium reductions, into reductions in claims payments for self-insured businesses, and potentially into more favorable cost-sharing terms as well, especially within fully insured insurance contracts. We'd also envision investing in higher payments for primary and behavioral health care. I will say more about this later, but this is an area we have heard about a lot since we've been in this office, and I think whenever I've asked, these are really the two areas that I've heard flagged both for access issues and from providers and hospitals in terms of areas where they wish there was sort of more investment coming in. And then reforming prior authorization to lessen administrative burden on providers. Another concern that we've heard is, use of prior authorization kind of proliferating over time. We know that from a consumer perspective, this is a challenge in terms of kind of experience and feeling like there's, so many administrative burdens to accessing their care, and heard from, again, hospitals and other providers about the administrative burden of responding to these kind of prior authorization requests. And there has been interest, I think, in this space over time in the legislature, but it is a challenging area to work in because often there is some cost associated with limitations on prior authorization. So the idea here is, given that this bill could generate savings, it could sort of more than offset additional cost and additional claims from reforms to prior authorization. So that's a high level. I'm about to go into a little bit more detail, but again, please stop me if anyone has questions or wants to discuss any more at this point. So starting with the price and price growth caps and thinking about next steps here, I will say we've had an opportunity to access available a TA essentially to help us with modeling of this policy. This is the type of policy that is complex enough that it really requires in-depth modeling. And the Urban Institute, who we have worked with before, you may remember early in the office's time, maybe 2 years ago, they were able to create some projections of healthcare costs and enrollment for the state of Maine. And they are able to help states through some grant funding to do kind of analysis of new proposals. So I say all of this by saying we have work underway to kind of get a better handle on this and be able to report back. But I think step one is really thinking about establishing the basis of a benchmark, in considering policies in other states and just internal discussion and research. I think using Medicare makes a lot of sense as the initial benchmark. That's largely because information is pretty transparent about what current Medicare rates are, relatively predictable. It removes some of the complication. The one other state that has used a different model is Indiana, that uses a measure of sort of median price in the market, but that can shift over time. The policy impacts it, how you manage that if you're trying to implement and sort of run a program over time is very complicated. So I think this is a much more straightforward sort of benchmark to use, and is also really the closest thing we have to an idea of what the cost of providing a service is, given all of the data and expertise that goes into the development of Medicare rates, especially for hospital facility payments. And once there's a sense of sort of that basis for a benchmark, establishing an appropriate benchmark level. I touched on this a little bit earlier, but trying to think through what are current payment rates and then what feels like a reasonable cap on prices as a percent of the benchmark measure. And then considering the scope of caps and exemptions. Again, other states have usually included exemptions for small and rural hospitals. And I think in light of challenges with financial performance in Maine, we could also think about exemptions based on financial performance to ensure that we're mindful of kind of stability concerns. So just a little bit of preliminary work, and I want to really emphasize this is very rough. We wanted to bring some information to just give a sense of kind of where things fall now, but very much going to wait on a more comprehensive analysis to bring any kind of real estimates. But just to give folks a sense of kind of where prices in Maine currently fall as a percentage of Medicare. This table shows just the general acute care hospitals, so critical access hospitals aren't included here. They're paid on such a different basis of Medicare that it's very difficult to make comparisons between the two groups, but ranging from just a little over 200% down at the bottom for St. Mary's up to over 300% at Cary Medical Center to give kind of a sense of the range. We're pretty solidly above the 200% mark and exceeding 300 in some cases. I think the average across hospitals is about 250% for the combined inpatient and outpatient services. And we've done some work just using RAND data to get a sense of what a variety of kind of different benchmarks could look like in terms of savings. So what this table shows is what those savings would look like at 200% of Medicare at the bottom, 225% in the middle, and 250 at the top. A couple notes, in this we kind of envisioned price caps not going into effect immediately, so there's a little bit of a delay here in the first couple of years that we estimated on that first line for each of the categories, but with price growth caps included for all the years. And as you can see, the savings here kind of range from about $10 billion over 10 years, using 250% of Medicare as the benchmark, to about $13.5 billion using 200% of Medicare as a benchmark. And this, I'm now forgetting if I said, so I wanted to say, is using RAND analysis, which pulls in claims data from Maine's all-payer claims database and does a repricing exercise to Medicare rates that are specific to the hospitals that are included, but it is at an aggregate level, so very much a rough estimate, but we wanted to do some work to at least give folks an idea of sort of what are the numbers that we're talking about with an idea like this. So increasing investment in primary care and behavioral health care. I might have, I feel like some of my bullets are missing, which I think might have been a version control error on my part, but I can just talk over them. So thinking about primary care, behavioral health care, again, just will reiterate, very much focus in the feedback that we've received on both the provider and the consumer side. What's involved in, I think, thinking more about building out this component of policy is an extra level sort of beyond, and when we're talking about hospital prices, I think there's a very clear definition of what facility inpatient and outpatient services are, and there's relatively easy ways to identify what those services are in data and in claims. Thank you. No worries. So I think step one is really thinking through what are the parameters of what we want to consider primary care and behavioral health care. So, we've given some thought to this. I know there's been a lot of work done through the Maine Health Data Organization in terms of their reports about spending on primary care and behavioral health care, thinking about kind of a intersection between provider type and coding type to identify this. I think in a model setting actual floors for prices or thinking about investment, there would probably need to be a kind of a simpler methodology. So we really thought particularly about focusing on evaluation and management codes. We've heard from some providers over time that the bulk of, let's say, a primary care practice's revenue is likely coming in through those evaluation and management codes. There may be some need, I think, to expand that through behavioral health care, but I wanted to kind of socialize that with the group. I think this question of, where specifically would more investment be helpful is one that we'll need to hash out and work through. And then thinking about establishing benchmark levels here as well. So when we talk about increasing investment in primary care and behavioral health care, we're really thinking about sort of following that model that the state of Washington included, though on a broader level, but thinking about kind of keeping with commercial insurance as an area of opportunity, just because there is an ability to kind of make adjustments to payments on the commercial side, where both the benefit of caps in terms of savings and additional spending through floors are kind of all exist within one single structure. Much less complexity than, for example, the notion of trying to estimate savings and bring in revenue some way and then send that back out through, for example, increased Medicaid rates. So the idea is, again, bring more investment in, but kind of use this vehicle of overall changes to insurance structure to do that. And like the caps, in thinking about where an appropriate kind of floor level would be for this investment, we want to take a look at current rates of payment and where those fall as a percent of Medicare. And again, weigh the prioritization of increased investment with delivering savings to consumers. There's the ability to potentially shift funding, maybe from hospital spending into primary and behavioral health care, but finding the right balance where there are still savings that potentially accrue, again, to people and to businesses is something that we're thinking through. So I think on the next slide, if hopefully, okay, we're good there. There is just, again, very rough estimate of reinvestment costs. And I don't know why, for some reason, the slides that are on the computer are different than what we're looking at here, but what this looks at is 110% of Medicare rates. And if we were to set a floor of 110% of Medicare for primary care and behavioral health care services. So what this looks at, again, is those different levels of what the cap sort of benchmark would be, but incorporating in a reinvestment cost line that is based on bringing up reimbursement to primary care and behavioral health care. So that's not to say, that's the right level, but again, we wanted to kind of give an example that puts some numbers around this notion.
Interesting to see that medical trend, what the additional cost without a policy would be, so we can sort of get a sense of the relative impact of the, say, over 10 years, the $9.2 billion. Without that, I don't know, premiums go up, what, 20 billion, 30 billion?
Yeah.
And so we can get a sense sort of what it does to trend over time.
Yeah, absolutely. That's something that is in the scope of the analysis that the Urban Institute has lined up to perform for us.
Right.
It's just outside the scope of what we can do. The complexity of
totally
integrating this into everything else does require like an actual economic model that only a few places possess, but that is, part of what we want to do, because obviously that's critical, understanding what impact these kind of estimates have. But again, I just think in conceptualizing this policy, at least having some sense of kind of magnitude and what does the relationship between the cost of that reinvestment component versus savings look like, I thought would be helpful as an illustration to folks. But yes, I will also say again, very, very rough estimates, especially in terms of primary care and behavioral health care. It's sort of a different data set than we have typically worked in, and so we used a different source for estimating some of those costs, the Healthcare Cost Institute's their data sort of database of claims. So again, not committing to these numbers. This is certainly not the final word, but just to give some sense of what we're talking about here. So then, moving on, I think I may have seen Karen Lee send a note, I think, about the primary care advisory council that just started meeting. Yeah, thank you, Karen Lee. I don't know for sure if others can see this, so I'll just say out loud that the Maine Health Data Organization has a new law that has authorized and created a primary care advisory council. And during that first meeting, investment in primary care was one of the primary themes when members were asked to respond about immediate need. So that's really helpful. Thank you, Karen Lee. Yeah, and I think just reinforces what I mentioned is like this has been such a consistent theme in the feedback that the office has heard over the years that we really wanted to try to find a way to address that. And I know I listened into the primary care advisory council meeting and appreciated the concept. You know, I think we're all in challenging times right now, and coming up with new investment is a really difficult proposition at this moment. So our thinking with this policy proposal is this is an opportunity to kind of, you know, shift around some spending and redirect it to a place where folks have really felt that there's been historic underinvestment. So then I think the final component that I wanted to touch on, and I know there is a slide that has all of the text on it, is incorporating changes to prior authorization. Again, touched on this as something that we've heard really consistently in all of our feedback, and understand, you know, the argument from providers, or the point from providers about the burden that this places and the degree to which it potentially even drives costs, that there's additional administrative overhead. At the same time, you know, want to balance that with the fact that there aren't a lot of tools in the toolbox, I think, for controlling and sort of trying to help manage costs within health insurance plans. And I think carriers, you know, would likely say that there are some elements here about being able to kind of monitor for care coordination and think more holistically about their role in kind of managing care for members that are important to them too. So we thought as a starting point, we could consider requiring carriers to comply with the existing laws on prior authorization that apply to the fully insured market as a condition of having access to the service level price caps that would be included in the law. So it would be an opportunity to kind of reach into the self-insured market in a way that we're often not able to because of preemption, because in this case, we wouldn't be directly requiring that them to do anything. It would be an incentive that if they voluntarily are willing to kind of opt into this, then they can access the benefits of service level price cap. Briefly, those limitations that currently exist in law are around the timeliness of a response from a carrier, 72 hours or 2 business days, or whichever is less for responding to a request for prior authorization. There's a prohibition on retrospective denials of coverage when a prior authorization request has been approved, with an exception if there's sort of fraud or misrepresentation. And then finally, a requirement that appeals be reviewed by a clinical peer who is not involved in the initial decision. You know, I've done some work looking at prior authorization limitations in other states, and I think Maine, in the law regulating fully insured plans, has a lot of the elements that are sort of discussed in other states, or that folks flag as most impactful. So I did want to say, you know, I think have a very open ear and would welcome input from advisory council members or others who are watching, listening, thinking about this, about opportunities that could kind of reduce the use of prior authorization. And I think specifically in cases where maybe services are almost always approved. So in the end, there's likely not going to be a significant cost impact, or where it really feels like, you know, prior authorization is maybe being used more to just kind of suppress care than to guide care to the most effective settings. So that's just an invitation for feedback. I've done some outreach to a couple members of the advisory council with questions about this, or requests for them to provide kind of recommendations or thoughts for us. But this is something we're continuing to think through and do research on, and try to determine, again, if there are some kind of relatively common sense changes that could be made that folks would view as beneficial to both providers and to consumers on net. Because again, we do have an opportunity here where even if maybe there is some marginal cost associated with a change in the prior authorization, it could kind of be offset by the savings from the program. So that is the last of my slides. I didn't do like a formal, wrap up, pause for questions, and I know we've got a little bit of time here. I know it's a lot to bring back to you, and things are, kind of moving quickly in terms of us trying to pull something together on this to bring back if there is interest from legislators or others in moving forward with a concept like this. So certainly more work to do, and I think really at the core of that is the modeling work, because without that, and a good solid sense of what the impact will be, hard to land formal decisions or a path forward. But I think particularly if there are thoughts or feedback on, some of the decision points here or design elements, would welcome that feedback from the advisory council.
I guess I'll add that I think it's good that you're pursuing this. I think it will be really interesting to see sort of the direction it goes. But as I've said many times in the past, it's price, underlying price, that causes affordability challenges within the state. Until we address price, everything else is going to be, from my perspective, largely nibbling around the edges. I think it's good that you've tried to incorporate some level of prior auth reform to address what I think are legitimate concerns from the provider community and from patients. So it sounds like you've put a lot of thought into this, a lot of work into this. I'm interested to see sort of what additional analyses come back, but I think broadly this is the conversation that we should be having.
Thank you, appreciate that, Trevor. And yeah, I should say I think in the kind of context that we're working in right now, again, with challenges on the federal level, but certainly I think at the last meeting we talked about, rate increases coming through. I think there is a real concern that, again, we're on a trajectory that's really unsustainable, and I know neighbors in other states have made it even further down that path, but right now at this moment where it is so difficult again for the state to kind of intervene on the affordability piece for consumers, I think changing that trajectory really feels like it is critical and very timely. And I certainly feel a sense of urgency around that, which is why we're trying to move quickly to pull together a well thought out proposal for folks to consider as they grapple with what can be the state response to the concerns that I know consumers are already feeling, given that open enrollment has started. They're starting to look at those costs.
I will say I do think that the nuance and the caveats are going to be critical in designing a policy that doesn't have potentially negative repercussions on some entities that are indeed facing financial challenges, as much as we can protect against potential closures or additional challenges, while still moving the ball forward on a sort of trajectory towards more efficient, affordable healthcare. I think that's where we want to be.
Thank you. Any other thoughts? If not, I'm thinking we put this in the chat. Yeah, thank you. I think good. I was going to ask if maybe Kate or Jordan, I was looking at which advisory council members are on. Maybe somebody can at least confirm that you can hear me and come off mute. I'm fine to kind of keep moving, but I want to just make sure that I'm not. Okay, Jordan's good. Perfect, thank you. I was nervous I was going to get a note later with people saying we were all trying to come off to give feedback and just couldn't for some reason. So appreciate that. Well, in that case, I'm more than happy to give time back. Again, I know several of us have been in a commission meeting straight from this morning through till now. So I know I'd appreciate an opportunity to have a snack and take a breath. But again, know that this is a lot, as always. So I will share these slides definitely, and also really happy to engage, as always, with advisory council members or for the folks kind of watching who may want to weigh in or share thoughts about this overall framework and concept as we think about these next steps to build it out. Always welcome that engagement. So please let us know if you do want to connect. Otherwise, I did realize we should maybe briefly touch, because I think we're in our last meeting of 2025, which is hard to believe, time flies. So moving into 2026, I know we're looking towards having a handful of new members confirmed, hopefully officially soon through the Senate. But did you want to touch at all, Kaylee, on continuing? Have we sent invitations for this time for?
We have sent invitations that I changed something on the admin backend. So if anyone can just confirm, and you can shoot me an email later that you have received the invitation, that would be helpful. Otherwise, those will be circulated by the end of the week if people haven't gotten them already. And they will be in the same building, but a smaller room when you come in to your left.
Perfect. Thank you. Yeah, and I think I'll just say again, I know we went through a few iterations of finding a time. I think this time still seems to generally be workable as it can be for the busy group of people who I know are part of the advisory council. But I always feel like the new year is a good moment to say, if anyone really feels like they have a major conflict, please let us know. And now would be the time to revisit. But I think we've generally got consensus that this on a regular basis is something that we're able to, that most folks are able to continue. Perfect. Thank you. I just saw Mallory, your note about reaching out to talk about PA burden for behavioral health providers. So that would be great. We'd welcome some time to just talk through that directly and get your input. Thank you for weighing in. All right. Well, with that, I guess we can wrap up. It feels wild to say that, we won't gather again until the new year, but I'm sure we'll be in touch, between now and then. If there are kind of major developments on this or updates to share, happy to do that more directly. And again, I'm sure we'll talk with all of you in various capacities more directly, but otherwise we will see you for the next meeting in January. Okay. Thank you all. Have a good rest of your afternoon.